Hello everyone. This is my first presentation on the topic renal oncocytoma. Coming to an introduction, the renal oncocytoma are usually solitary masses and these represent between 3 and 10% of all renal tumors. It is generally considered as a benign neoplasm in majority of the cases, and the first renal tumor was described by Zippel in 1942, and at that time it was considered as a rare renal tumor. But now, oncocytoma is regarded as the second most common benign renal neoplasm only after angiomyolipoma. And the commonest benign renal tumor is the renal cyst. Oncocytoma, however, is the most common benign enhancing renal mass. Coming to epidemiology, up to 25% of the renal masses smaller than 3 centimeter represent oncocytoma, and it is a challenging diagnostic entity in clinical practice. They have a male predominance and are usually solitary and unilateral. It is a benign disease, and however, in some cases, metastatic diseases have been reported, but it is extremely rare, and even in those cases, it is likely to be eosinophilic chromophobe RCC. The pathology presents as a diagnostic dilemma due to overlapping features with eosinophilic chromophobe renal cell carcinoma, succinate dehydrogenase deficient RCC, papillary RCC, and however, on based on the gross appearance, it appears mahogany brown with a surface with a variably present central scar. And on histology, it is strongly eosinophilic because of high mitochondrial density with nest of tubular structures arising from the distal tubule. The nuclei are round to polygonal and regular with abundant fine granular cytoplasm with extremely rare mitotic figures. These can be associated with perirenal fat invasion and renal vein invasion. However, in case of oncocytoma, they do not carry any prognostic significance, whereas these carry prognostic significance only in renal cell carcinoma. And this is a histological image showing the eosinophilic cells because of high mitochondrial density, and the nuclei are round to polygonal. Another important feature is that the colloidal staining can show variable results in oncocytoma. However, the hallmark is negative staining for oncocytoma and diffuse reticular staining in cases of chromophobe RCC. And when typical features of oncocytoma are present, histology and morphology are alone sufficient for diagnosis. In morphological variants, there comes the role of immunohistochemistry markers. The most important is the cytokeratin 7 used in cases of diagnostic dilemma between chromophobe RCC and oncocytoma. The CK7 is negative in case of oncocytoma, CD117 is positive, Vimentin is negative. But however, when the biopsy is taken from the central scar, it can stain positive for Vimentin and CK7, which can cloud the picture if this is not taken into account. Coming to the genetics, it is typically associated with loss of chromosome 1, X or Y chromosome, or 14 and 21 chromosome loss, also with rearrangement of 11q13. It also exists in patients with Birt-Hogg-Dubé syndrome and renal oncocytosis. Now, renal oncocytosis is a condition which is characterized by presence of numerous bilateral renal oncocytoma. And coming to Birt-Hogg-Dubé syndrome, it is an autosomal dominant and the mutation in folliculin gene on chromosome 17. It is associated with pulmonary cyst spontaneous pneumothorax, and cutaneous fibrofolliculoma. So these commonly develop chromophobe RCC and oncocytoma. Coming to the symptoms and signs, up to 3/4 of the patients with renal oncocytoma are asymptomatic. So the majority presents as an incidental finding of a renal mass, which is usually unilateral. In cases where the mass is large, some may present with hematuria, flank pain, and palpable mass. And the characteristic is unifocal, but however, multifocal and bilateral concomitant renal cell carcinoma also have been reported. Now, how do you evaluate? So, definitive diagnosis of oncocytoma is typically post-operative diagnosis. Now, there are, however, imaging clues which can aid in diagnosis, but there is no standard guidelines as such. On CT axial cuts, there is usually a hypervascularity seen. Tumors are hypervascular and may present with a central scar. Multiphasic MRI is currently being evaluated, and there are various studies which shows advantages and also disadvantages, but however there are further studies which needs to be done. And SPECT, which is the single photon emission CT with technetium 99, showed specificity of 95.2% and sensitivity of 87.5. Coming lastly to renal biopsy, it shows low positive predictive value of only 67%, and it is not routinely used due to the low positive predictive value. This is a contrast CT showing multiple renal masses, which is showing bilateral renal oncocytoma, is known as oncocytosis. And again, this is again a contrast CT which shows a hyper enhancing mass with a central scar which is stellate, or in cases of such as spoke wheel pattern. Now, coming to the MRI, the MR appearance is variable and non-specific. So they are hypointense on T1 weighted images, but vary in signal intensity on T2 weighted images. And they are often well defined. They have a well defined capsule. The central scar, which when present is seen as a stellate area of low signal intensity, and on T1 images, but on T2 images the signal intensity is high. And this is a comparison between clear cell RCC and oncocytoma. The figure A is an axial contrast CT showing a heterogeneous mass in the left kidney, and the B image is again technetium 99 SPECT imaging, and the C is combined images with technetium 99 sestami B SPECT CT images, which shows no evidence of radio tracer uptake in the tumor. And this, coming to the next image, D, it shows an axial contrast enhanced CT image showing another left-sided renal mass, and the same image in technetium 99 SPECT CT, and this the final image F is the superimposed CT with SPECT CT images, which shows a intrinsic radio tracer uptake with highest uptake in those part of the mass with most avid ENLA enhancement. Now, the technetium 99 sestami B is widely used for imaging parathyroid adenomas, but and has been recently shown to accumulate in oncocytic renal tumors, which has high levels of mitochondrial content such as benign oncocytoma. So differentiation of localized clear cell RCC from a benign renal oncocytoma here has become much more easier. And how do you identify a benign renal mass? Certainly there are clues to benign entities such as thin and enhanced walls in a simple cyst disease or macroscopic fat in an angiomyolipoma. However, these are not universal, and therefore most diagnoses are made at biopsy or resection. So additional clues to diagnosis of benign histology include smaller mass size and lack of growth in serial imaging, female sex, and older age. And these are findings which help in identifying benign diseases. However, none except the lack of growth over time can reliably rule out malignancy. And coming to CT angiogram, oncocytoma have a typical angiographic appearance, but however, it is not the characteristic. The spoke wheel appearance is the one of the characteristic, but however, it can appear in other lesions as well. It appears due to the arterioles around the mass, and the capsule gives a loosened rim sign. Even these features can be seen in some of the renal cell carcinoma. Now, coming to a brief comparison between the chromophobe RCC and oncocytoma, this the reason why I'm telling is most of the features overlap with the chromophobe RCC, and it is very difficult to distinguish between the two. And on gross findings, the chromophobe RCC appears beige in color and homogeneous texture, whereas the oncocytoma appears mahogany brown and presents with a central scar. In microscopy, the chromophobe RCC appears solid, sheet-like, tubular, cystic. The nuclei appear cleaved, and it has a definite cell boundary. The stroma is hypervascular, and colloidal stain is diffusely positive. Whereas in oncocytoma, the architecture is alveolar, organoid, or solid tubular. The nuclei appear round, cell boundary is obscure, stroma is edematous or hyalinized, and another characteristic finding is negative or positive limited to the apical surface. Immunohistochemistry plays an important role in identifying the two, and chromophobe is positive for CD82, and CK7 is diffusely positive, and S100A1 is negative. Whereas in oncocytoma, CD82 is negative, CK7 is focally positive or negative, but the S100A1 is positive for oncocytoma. Electron microscopy shows numerous microvesicles in chromophobe RCC, whereas oncocytoma contains abundant mitochondria. Cytogenetics consists of multiple chromosome losses in chromophobe RCC, whereas in oncocytoma there is deletion of chromosome 1 or chromosome number 14 or translocation involving the 11q12 or the 13 chromosome. Coming to the management of oncocytoma, so these lesions are managed based on the perceived risk of renal cell carcinoma and can vary widely from no management to radical nephrectomy. And since there are no preoperative diagnostic differentiation between the oncocytoma and RCC, most patients undergo radical nephrectomy. And most of the cases of oncocytoma are diagnosed after surgical resection because of, again, the perceived risk of RCC. So the mainstay of management is only post-surgical observation. In cases which have been biopsied, active surveillance has been explored, and it has a very favorable results with a 100% 5-year cancer-specific survival. When oncocytoma is suspected but uncertainty exists or treatment is indicated, we can go for nephron sparing surgery, and these would be the standard when technically feasible given the benign nature of the disease, and these include ablation or partial nephrectomy or enucleation or wedge resection. Coming to summary of my topic, renal oncocytoma is the most common benign enhancing renal mass. This is histologically similar to chromophobe RCC, and immunohistochemical staining may be required to distinguish between the two. Practically, it is difficult to differentiate oncocytoma from clear cell RCC, and oncocytoma is associated with Birt-Hogg-Dubé syndrome, which is characterized by pulmonary cyst, spontaneous pneumothorax, and fibrofollicular mass. When suspected, a percutaneous biopsy may provide a diagnosis when core tissue is available for additional immunohistochemical studies. But however, percutaneous biopsy is usually not indicated except in very rare situations. Active surveillance represents a reasonable treatment strategy that minimizes the risk and also increases the certainty based on growth kinetics. And with this, we come to the end of the chapter. Thank you for listening. And please do voice in your comments on the comment section so that it may improve uh, on the next presentation, and will be really helpful for me in improving the presentation. Thank you.